Your passcode has been confirmed. If you need technical assistance during your call, press *0.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign. There are 25
parties in conference, including you.
It's not a sentence where they have to be addicted, but there is something to be said about genetics. Physical health can also appear like a mental health issue. So, for example, a thyroid problem can cause someone to have depression. Brain tumors, dementia, metabolic problems, and nutritional deficiencies can cause hallucinations and even delusions. Lyme disease, syphilis, diabetes, epilepsy, they can cause symptoms of depression or even psychosis. So when somebody has a mental health issue, it's always important that we rule out anything medical. So as we're talking, if things come up, don't forget to, you can always say, you know, have you considered, it's okay if somebody goes to their doctor first. If they come to a clinician, a counselor, we're always going to try to rule out the medical first. That's one of our code of ethics almost. A rule of thumb, I guess, is we always try to rule out medical. And then, of course, personal experiences. We mostly think mental health issues come from only personal experiences. But, of course, if you have a traumatic experience, that can impact how you see the world, how safe the world is for you. And it can also impact how we respond to others. And then, like we talked about, a family history, genetics. So not only what's the capacity of your individual brain to deal with stress and other factors, but also what are the genetics. So all of these play a role in each other. So many people think that mental health only affects the way people think. And it can affect their perceptions about themselves, their perceptions about others, thoughts about a situation, how they respond, and the choices they make. So it's a big triangle, and all of that goes into the middle of the perceptions, and that determines how they respond. So let me give you an example. For example, Susie lost her husband of 35 years. She functioned really well for a few weeks, but as the realization of the loss of her husband set in, she became depressed. As you can imagine, Susie's mood was sad, but she was also really irritable and angry. Susie had difficulty managing her thoughts. She had difficulty concentrating and even organizing her thoughts at times. She would start a conversation and then just kind of trail off without completing the sentence. Often her coworkers would see her zone out. Her hygiene and appearance weren't the same. She talked about having difficulty sleeping and had lost her appetite. She had little patience and was very short with others. Susie started to notice people were avoiding her and growing irritated with her. She then viewed everyone as difficult to get along with and became more and more openly hostile with with others. And now she saw the world as a more negative place. So that is an example of how mental health problems can not only affect a person's mood, but how one's thoughts about oneself and others can affect the environment and then their future decisions. Susie's actions changed when she started withdrawing, but her perception of the world started to change too, and so she started to see things more negatively. So this is not that uncommon. You get in a place and you start to see what you're looking for. And so these changes can cause a serious problem in one's personal or social or even your work life, and can indirectly even lead to physical illness and even early death. However, on the bright side, this can be helped. So there's some myths that we have about mental health issues. And if we were in a room, I would probably ask you to throw out some of those myths. But since we're on a webinar, then I'm just going to go from here. So there's some myths that people think that those with mental health issues, especially if you don't understand it, we think they might be violent. But actually, only 3 to 5% of violent acts can be attributed to individuals with this serious mental illness. In fact, people with severe mental health issues are over 10 times more likely to be victims of violent crimes. These people are weird or crazy. So the idea that someone could develop mental health issues is scary. And mental health can change based on biology, but also life circumstances. And we can't always know what to expect. So because we don't know, and it seems odd to us, we start to call them crazy or call them weird. It's also kind of a coping skill of a way of reassurance. I'm not like that. That couldn't happen to me. And so they're just crazy. And it's actually very common. Mental health issues are very common. If you think about depression, if you think about having, I use depression a lot because it could be just a confluence of factors. It could be a loss. It could be you just had multiple losses at one time. So life, like I like to say to people, life happens. It's not simple. It's not uncomplicated. So we could all at some point have a mental health issue. And that's okay. We can get treatment or help. So people with these problems can't work normal or good jobs. There's probably a lot of people that you know struggling with a mental health issue, but you're just not really aware of it. They could be coping very well. They could be on medication for it, but they've learned how to deal with it. And a lot of people have coped and know how to deal with their issues. They know signs. I used to have clients that would come in knowing that they were on the brink of going into a depression. They knew what was happening, and then they sought out help, and they avoided that. And you may never even know that, and that is fantastic. But we kind of feel like we would know, and that's not always true. Another myth is that they're weak or they're lazy. Remember that the root of mental health issues can be family or life circumstance as well as genetics or physical makeup. It's not really a choice. People don't choose to be depressed or choose to have a mood disorder, but they do have a choice to get better and get help. So Stephen Fry, that's who you see right there, is an accomplished British actor. And you might remember him, for those of you in my generation or older, from the movie A Fish Called Wanda, or as the psychiatrist in the TV show Bones. He actually suffers from what many of us would either call manic depressive, or maybe you know it as bipolar disorder, but he's very successful. He's learned how to work within his mental health issue to be successful and to continue to be successful. And he might not be somebody that you would even imagine has any kind of problem. He's very successful. He's very wealthy. He's very accomplished. He comes across very this confident English gentleman on TV, and so we wouldn't assume that. But that is your typical picture of somebody that might be dealing with a mental health issue. So it's very common. It's a lot more common than we think. So what we have the power to do is alleviate some of that stigma. Friends, family, and supportive people in someone's life can counter-effect these. You're a supervisor. You're a very important person. You have influence in your employees' lives. And so you can also counter the effects of these stigmas. So what happens with these stigmas? This is the problem with stigmas. If people don't understand, people don't understand the mental health issue, the person suffering from that mental health issue could get discrimination at work. If they're young, they could get discriminated at school. They could have difficulty finding housing. They could be victims of bullying or physical violence. They might not be able to get health insurance that adequately covers it, or afford the health insurance that adequately covers it. And then what happens is they might start to think that that's who they are, and treatment's pointless. Or they might feel like if they go to treatment, everybody's going to know they have a problem, so they don't want to do that. And the shame in that is that it's, like I said, it's very treatable. Sometimes you add medication just to kind of tweak the person to a more even-keeled level, and sometimes you don't. Sometimes it's a lot of, it's always hard work, but sometimes it's just simply hard work and getting things situated and learning how to cope with situations and having a plan. So, but if we stigmatize and we're fearful of it, then that person's not going to want to come forward and say that they have a problem. So when we look at mental health issues, I want you to think of it as on a spectrum or a continuum. It can go from very mild to someone having just some transient emotional distress to having severe mental problems. And it's all along that continuum. So if one person has bipolar, they may react totally different than another person with bipolar, or one person with depression has a reaction totally different than another person with depression. And it's a continuum, and it just depends on their individual factors that are at play. The more severe the problem, the more it can affect work or their personal life or their relationships. But again, with treatment, it can be restored. And so although a reaction to a situation may even seem crazy to an outsider, as we're talking about this, I want you to remember that a person responds according to what makes them feel safe or what relieves the most distress. So, and we're going to continue talking about that so we can understand those reactions. So here's some common mental health problems. And you have probably seen a little bit of all of this as a supervisor. Some are hidden. Some, I mean, who hasn't seen stress and anxiety? You've got a deadline, your workload's high, something's got to be, or a report was done incorrectly, you've got to get it in, or somebody's doing an audit or something, and or you're getting a performance evaluation, you're giving a performance evaluation, all that. I mean, that's every day, right? That's just stress and anxiety is very normal. Sometimes that can impair functioning when it gets too high. We're going to talk about difficulties in adjusting, life changes, life events, depression, bipolar, alcohol and substance abuse we're going to touch on as well. We have a whole alcohol and substance abuse training, but I do want to touch on some things with that. And then trauma and PTSD, that's post-traumatic stress disorder. I'm going to go through the first 5, but then I'm going to really focus on trauma and PTSD because that seems to be kind of a hot topic right now. There's a lot of concern. I know a lot of our customers really want to know about that. They might have a lot more interaction with people that they might assume have PTSD. And then you've heard about it a lot on the news with violent crimes that have occurred, and the newscast unfortunately assume PTSD as well. So I want to kind of clear up some myths about that and also understanding, some true understanding. So I'm going to spend a significant amount of time on PTSD, and I'm going to go over the rest of these as well. So let's start with anxiety. Anxiety is completely normal. It's a part of life. If you don't feel anxious in your life, then you might have a mental health problem. No, I'm kidding. Then, everybody has anxiety. You have anxiety before. Anxiety can be anything from nervousness or all the way up to excitement. You're just exciting anticipation of something. So that can be, it's all the same physical reaction. So you can give it before you take you can get it before you take an exam, before you give a speech, before something unanticipated. I had major anxiety when I was 4 minutes away from this conference and my computer was not working, but that's okay. So sometimes it's a good way to think of it in general, in most terms, is fear. And it could go from slightly distressed to extremely fearful. And you may have heard of some common names are obsessive-compulsive disorder, that's an anxiety problem, generalized anxiety disorder, phobias, panic attacks. These are all problems that result from difficulties with anxiety. And for some people, due to their physiological makeup and not understanding how to cope in specific situations, anxiety may occur too often or to such an excessive degree that they're unable to control it. And so these symptoms can cause significant feelings of distress and interfere with their ability to lead a normal life. And basically, anxiety comes out as a physical symptom. So you see a lot of physical symptoms in here. And so as anxiety increases, the physical symptoms increase. And these problems, if the anxiety is significantly affecting a person's normal function, can often be treated with counseling or even sometimes anti-anxiety medication. The common factor in extreme anxiety reactions is that there's a component of fear and a physical reaction. People with anxiety generally know that they are worriers or that their reactions are not typical to that situation or object. They might even want to share or talk about it, or they might not want to because of fear of being judged. And so most people with anxiety want to feel different, and they just don't know what to do about it. So it's a lot of times I see this, it was very eye-opening to me as a young person when I met somebody before I ever became a counselor with obsessive compulsive disorder. And she said to me, I never said anything. I just said something about how I thought it must be difficult. I didn't know she had it. And she said the worst part was that she knew she had OCD, but she couldn't do anything. It was too anxiety-provoking to do anything about it. To not do, so OCD is when you have major anxiety and then you do some sort of action, a compulsive behavior in order to relieve that anxiety. So hand washing or the counting, the number of times you touch the doorknob or whatever, or germs or whatever. And so she knew it, and she knew the whole entire time that she was doing this compulsive behavior that it wasn't normal, but it was so relieving of that anxiety that she didn't know how to stop. So I just want you to think of anxiety that way. Difficulty adjusting. These are in our clinical terms, or what used to be V codes, but you can have a marked reaction, a stress, a marked response to something such as a job change, moving, an illness, a marriage. It could be something very positive. It could be that you got married, bought a house, and got a new job or a new position all at the same time. That could be really overwhelming. It's a lot of change, and it depends on how much you like change. Most people aren't real fond of change, so it could be really uncomfortable. And of course, obviously, a car accident or a death or a divorce, that obviously would, make you think that would be a stressor. But remember, it can be positive things, too. So an adjustment difficulty happens when a person's overwhelmed or they have difficulty coping or adapting to the level of intensity of the event. And so they're having difficulty coping, but that's unique to each individual. And it just depends, and then it can cause a certain level of distress, and that's when it becomes a difficulty in that adjustment. So people going through a difficult adjustment period may seem nervous or panicky or sweating or even be sad and hopeless or having times where they're just really what I would call tearful or crying. They can also talk about difficulty sleeping, or they may just seem tired. They may respond with an agitated or irritable response. They may argue. You sometimes even see vandalism, fighting, or even legal problems. So it's important to note that people may have adjustment difficulties with changes, like I said, to the outside that are positive, but don't assume that they have no reason to have that adjustment difficulty. Just because you think it's a positive, you may say, well, I would have loved that promotion. Why are they having a difficulty? So it's individual, and they're responding to that on their own. Or you promote somebody, and then all of a sudden they have anxiety. That's okay. That's up to them. And so this is very, very, very treatable. They just need time to adjust, really. And that's a lot of times there's no formal mental health that's needed. A lot of times it's just the passing of time. If it continues and the anxiety does not decrease, then they would need to get some help. So if you promote somebody and they have give them a period of time, or if you change somebody's job and they have this difficulty adjusting, they're panicky, they're anxious, whatever, give them a period of time, but if we're looking at months and they haven't, and they're still panicky and anxious, then they might, it might be good to suggest EAP. Have you ever thought, I noticed that you're kind of nervous, have you ever thought about EAP? Or do you know we have this service? Depression. So everybody occasionally feels blue or sad. If you were on my suicide prevention talk over the last couple of days, you've got an earful about depression, but I'm going to go over some of the common features. So if you're blue or sad, that's usually very short-lived, and it passes within a few days. If you're grieving, you can be in a depression, so to speak, but you're grieving, that's not unhealthy, and it could be months. That's fine. Really, when you talk about depression and it being a problem, it has to interfere with your daily life for a significant period of time. And it usually causes pain for the person that has depression and those that care about that person. About 25 million Americans will have an episode of major depression this year. And there's several forms of depressive disorders, but most have a combination of symptoms that interfere with a person's ability to work, sleep, eat, study, reading, and enjoy activities that they once found very pleasurable. Sometimes people with depression don't appear stereotypically sad, but rather they can come across as irritable, sometimes self-absorbed, and sometimes even angry. And that's not very uncommon, and it's very typical of depression. Some types of depression, like major depression, can be very disabling and prevent a person from functioning normally. And some of those people may experience depression only once, but often you will see these depressive disorders reoccurring. And this is assuming there's not active treatment going on. And depression can be a result of genetics. You will see families, well, you won't. I've seen families where they have a history. You know, mom was clinically depressed, and now the daughter has a history of clinical depression, or the uncle, and, you know, you'll just kind of see it trickle throughout the family. So it can be a result of that. It could be a result of situations that occur, like we said, grief or a traumatic experience. Often there's a grief cycle that goes on when you have a trauma, and then psychological and biochemical factors. And it can actually change the chemistry in the brain. And so a person may need medication because we're learning more and more that the brain and the body are very much in tune, and the neurotransmitters are very much in tune, to the point that if you fake an emotion, your neurotransmitters can often change your neurotransmitters. So just by the act of smiling, it will change the impact on your brain. So even if you aren't happy. So that's what I mean by that very, very close connection. So if you're depressed, then you have brain changes and you might need, you know, medication. It doesn't have to be permanent. It doesn't have to be a lifelong sentence. It may be something temporary to get everything leveled off and then to come off that medication. So as you look at these symptoms, they're probably all pretty obvious, but I want you to know that it's a combination of these factors that will raise a red flag, not just one individual symptom. Just because somebody's sad or they lost weight really quickly does not mean that they're depressed. But if you look at all of these, and they don't have to have every one of them either, but, you know, and sometimes you only need one. If somebody says, I want to kill myself, then you can pretty much assume they might be depressed and that there's a problem. Okay. Bipolar. So this is more than, a lot of people say somebody's bipolar, and really what happens is this person's just moody and hard to get along with. And, but bipolar, true bipolar, is more than moodiness or being dramatic. When somebody struggles with bipolar disorder, they have manic stages as well as depressive. So manic, I'm going to clear up, because a lot of people think manic means happy. Really, I like to think of it personally as uninhibited. And so they may appear highly energetic and creative, but they may not be productive. They may think that they're productive, and they may think, so that you may see these grandiose, oh, I can do this, and I can do that, and I can do all kinds of things, but they actually may not be very productive at all. Easily distracted, don't make great judgments. A lot of risk-taking behaviors can go on. A lot of times in a manic state, you'll see people, not a lot of times, sometimes when people are in a manic state, because they're uninhibited, they might become more violent. In my experience, this is when somebody already has a propensity for violence, and then when they're in the manic phase, they then act on that violence. But again, I just want to clear up, it's not happy, it's uninhibited. They may spout out workplace rules. They may tell people how to do their jobs. And again, this is not difficult personalities. This is a mood disorder, and this is an extreme. A lot of things, sometimes you see they'll have racing thoughts. they'll have so many, it's almost like they have so many words in their mouth they can't get it out. So these are all kind of some factors of that manic phase. And other, you know, like I said, one person with bipolar disorder does not always act textbook, or they don't act exactly the way somebody is, but it's just beyond moodiness. So then what they may do is cycle later into a depressive phase. And there's different levels of bipolar, and I'm not going to get into all that because, again, I don't want you to learn to be a therapist. I just want you to be aware. So if you see somebody that's uninhibited and acting grandiose and easily distracted and feels like they are conquering the world and they're not very productive, and then they move into this quiet, withdrawn, sad, not very motivated, still can't concentrate, losing weight, feeling hopeless, and then they move back, you know, that kind of thing. You might be working with somebody that has bipolar disorder. So, and again, I'm going over these briefly because, again, I don't want you to feel like you're in a position to be a counselor. I know I'm harping on this, but I really don't want there to be any confusion. And if you have any confusion about this, because I'm going over very, very briefly, if you want to know and you're like, gosh, that person acts a certain way, I wonder if that's what's going on, then call EAP and we can help figure out if they need help or if it's something that warrants treatment or they would benefit from getting counseling. Okay, alcohol or substance abuse. You may not even know. They might not have any kind of symptoms. When you're looking at this, it's real important that these are the observable things. And you have to draw reasonable conclusions. So these are some of the indicators. You know, of course, they have the red cheeks or the red flushing on their neck and their chest, not really giving a lot of facial expressions. Their grooming's down. They can't coordinate. They're stumbling. Runny or bleeding nose could be a substance abuse. They smell like alcohol. You know, their pupils aren't normal. They're either tiny or they're really big. And they have complaints about the temperature. So drugs and alcohol can affect your bodily temperature. So they might be extraordinarily hot or extremely warm. Some of these physical symptoms may not be apparent, especially, you know, and somebody may not have very good personal grooming at all. And so you may never know if there's substance abuse behind it or they had a long history of it, so they've always looked this way. There wasn't any change. But when you deal with this, it's important to draw from specific, timely, describable observations. And when you, I want to go into a little bit that when you're documenting this, because this gets into HR and employee labor relations. So it's really important that if this is what you're concerned about, that you do include, and I'm sure, Sherry, you could add on to this, you do include ELR and let them know what's going on and document factual things about not just, go ahead.
I was just going to say, yeah, this is Sherry. If you have a situation where you suspect an employee is at work and is under the influence of some type of substance, then, you want to document your observations and probably have another management official observe them as well so that we have more than one person's report to go on, and then, contact me and we can talk about, how do we get the employee out of the work environment, what type of action do we need to take, what kind of referral do we need to make, and those sorts of things. But it's really important to document what you're observing.
And the documentation shouldn't be they looked drunk. It should be they were walking, they were stumbling, they were erratic, they smelled of alcohol, things that are just factual rather than
emotional.
Yes.
And we're not, we don't have the ability to do any kind of breathalyzer test or, any kind of blood alcohol type testing. So it's all based on your observations.
Okay. So what you may see with alcohol or substance abuse, these are behavioral changes that you may witness. And if somebody is abusing substances or alcohol, then you might see moodiness, irritability, inappropriate behavior, obviously, you would probably expect that, but also paranoia, anxiety, irritated, jumpiness. They might be very not alert, then they disappear for a minute, come back, and they're completely alert, or vice versa. You could also see disorientation and hallucination. So you might think somebody's a lot of times when somebody presents as psychotic, my first question is if they've used any drugs or alcohol, if they're having hallucinations or disoriented or something like that. However, I want you to notice that a lot of these can also be symptoms of trauma, anxiety, depression, or any other mental health problem. But if you have these symptoms and then you have the smell of alcohol, or you have the pupils are dilated or pinpoint pupils, that kind of thing. Again, I'm not asking you to be an expert, but if you notice these things, just keep an eye out of what these symptoms are so that you can put it together, so you can put those pieces of the puzzle together, and then we can kind of determine what level of care they might need. Okay, so any questions about those so far? Because I'm about to go into PTSD and trauma, which is going to be a little extensive. But anything, I know I went over that really briefly. Any questions about any of that so far? And you can also chat with me as far as asking a question if you're not comfortable saying it out loud. Okay, so let's go into trauma. All right. So post-traumatic stress disorder is what PTSD stands for. And I'm going to spend a lot of time on this, and I think it's something that most people have the most concerns about. It's very common, but it's also very treatable. And I know this as a PTSD treatment provider, I guess I should say. And I know that it's also very misunderstood in the behavioral health world. And it can occur, but it's one of the only issues that occurs, it's purely external. So I say that, but it's one of the only diagnoses that occurs after an outside event happens. Somebody can go into depression without having an outside event occur, or they can go in, they're bipolar, you know, or they develop, you know, they've had a schizophrenic break or whatever. That's generally there's an internal factor going on. Trauma is completely different. It's one of the only ones that's based on an external factor. So what are those external factors? So trauma comes from the Greek word a wound. And so we're going to talk about the different ways that people can get wounded. And there's many sources of trauma, and these are all just some of them. But all of them should produce some sort of extreme fear for yourself or for someone else. And notice that it's not just military combat or being a prisoner of war. And it can be a car accident. It could be childhood abuse. It could be watching somebody else get in an accident or somebody else die or somebody else be abused. So it could be witnessing these events as well. And actually, I want to stop. It could also be, because you can also get vicarious trauma. This is very common in healthcare workers, therapists, and law enforcement. And probably a lot of park rangers, considering if they've seen, you know, I know some of the parks have a high rate of people trying to commit suicide. So you could, by being involved with that, that could also be a result in having a traumatic reaction. So what is it? It's basically a set of symptoms that happens after a traumatic event. So the person either directly experienced it or they witness an actual or thought it was threatened death or serious injury to somebody's safety. So like I said, they don't have to think the person's going to die, but they have to think the person's in extreme danger. And basically the common factor is an intense fear, helplessness, and horror. So it's basically, the way I describe it to clients when I'm working with them is that you're having a very normal reaction to a very abnormal situation. And it's something that could happen to anybody. We're going to talk more about that. So what happens when you develop PTSD? And I just want to say not everybody develops PTSD. You have a lot of people that have been exposed to trauma, and they don't necessarily have to develop PTSD. There's some internal factors there, but it would not be uncommon if somebody did develop it from especially repeated traumas, and especially if there's somebody close to them or there's some sort of betrayal, that kind of thing. It just depends on the relationship to the person that's doing the trauma or the level of violence. So you don't always, so just because somebody's traumatized doesn't mean that they've actually got PTSD or have symptoms of PTSD. Okay, so what are they? Basically, there's 4 categories. So re-experiencing means they have flashbacks. This is not like what you see in the movies. This is feeling like you're in the moment, but the movies really exaggerate this. They have the guy trembling in the corner and he's hunched down and he can't tell where he is. The flashbacks that I've seen clients have are more like they're lost in the moment, but you can ground them and bring them back. Now, you can have extreme flashbacks. I'm not dismissing that, but I just think that what most of us see is what's on TV, and I just want to clarify that that's kind of blows it out of proportion. Recurrent memories. Intrusive thoughts are thoughts that you don't want to have, but they just pop into your head, and they can actually be scary thoughts that don't have anything to do with trauma, but just these morbid or very violent pictures that pop into your head. Nightmares, and then intense reactions to reminders. Reminders could be anything from a smell, a touch, a taste of something, seeing a color, anything like that. I've had people have reactions to seeing, like if it was a personal trauma, an assault, they'd have reactions if they saw a car that was similar to the person that hurt them, the same kind of car. It could be something like that. It could be a song that sounds similar to a song that they listened to while they knew that person that traumatized them. So it could be all kinds of different things. The other common factor is, or common symptom is avoiding things that, of course, because why would you want to remember the trauma? So what people do is what I call numbing out. They're zoning out, they're off in space, they don't feel anything. They might describe, I don't know, I don't feel anything, or I don't remember anything. They're trying to avoid that. They might withdraw from people. They might try to detach because they might not feel it's safe to have attachments. They might have a lack of interest in activities. So again, this sounds a lot like depression as well. A lot of times they can't remember certain aspects of an event. I've had people that couldn't remember their entire childhood because their childhood was traumatizing, or they could remember all the way up to the abuse, and then they couldn't remember after that. And you might see this with that, I'm saying child abuse, but it could be the event that was traumatizing, whether it was a disaster or in war or something like that. And then because they're trying to cope, and numbing is such a great way to cope, and because it makes you not think about the trauma, it's getting you through, then you're going to see a restricted range of emotions. They're not going to be very expressive with emotions. So people who suffer from PTSD also experience symptoms of increased arousal, including problems with sleep, being irritable, they have angry outbursts, problems concentrating, hypervigilance, and they have an exaggerated startle response. So they're really, jumpy. They're on edge. They're on edge. They're agitated. They can't calm down. They can't relax. Because when you are traumatized, you were hurt. So your body naturally is going to put you back into an alert phase. And you need to be on alert because it might happen again, is what your brain's telling you. And so your brain's trying to protect you. Okay. So what are some other issues that you might see with PTSD? It's very common for other conditions to occur. You can get depression, anxiety, of course, substance abuse. So if you think about people not wanting to remember, if you just want to forget about your day, a lot of people will take a drink. And some of you may have felt that way, like, oh my gosh, I had a horrible day. I just want to have a beer. And I'm not saying that's the best coping skill, but there's nothing wrong with having a beer if you don't have an alcohol problem, you know. But, you know, if that's how we feel after having a bad day, and some people do, then you could see if it was an intense emotion, an intense experience, it would be very appealing to turn to drugs and alcohol if you really wanted to forget. And that doesn't really work in the long run, but it works in the immediate. That's why you see people do that so often, because it works in the immediate need. And more than half of men with PTSD also have problems with alcohol for that reason. And women, the most common co-occurring disorder is depression. And so just under half of women with PTSD also experience significant depression. So men tend to turn their problems outward, get more aggressive, act out, maybe even lash out to other people. I don't mean violent, but just kind of snap or agitated. And women tend to turn inward and get depressed. So people can also, with PTSD, also might have problems with daily functioning. So generally, people with PTSD have more unemployment, more divorce or separation, more spousal abuse, and a greater chance of getting fired than those without PTSD. And people with PTSD can also have a wide variety of physical symptoms. So some evidence shows that PTSD is associated with increased likelihood of developing certain medical disorders, but this is ongoing research. There was a study by Kaiser that related an enormous amount of, well, basically early death of an enormous amount of different physical illnesses to adverse childhood experiences. So trauma can and does, research does show it does impact your physical health as well in the long term. And if you think about it, it's an ongoing stress, and it really taxes the body. And so when people can't deal with that stress or cope with that stress, it can create difficulties for the body and then ultimately physical illnesses too. So that's what the research is showing. I don't want to say that conclusively, but there is some very strong research showing that. So there's also a number of neurobiological and physiological changes that are associated with PTSD. So changes in the brain wave activity, changes in your hippocampus and your amygdala, that's your limbic system, that's your emotional center of the brain. And it also processes memory. So you do have some people that actually lose memory, and there's research that shows that when somebody's traumatized, you release hormones that actually eat away at the memory portions, or the part of your brain that controls memory, and you will lose those memories sometimes. Okay, so how common is it? So about 8% of adults in the U.S. have PTSD at any one time. Now, like I said, most people exposed to traumatic, or many people, about half, that are exposed to traumatic events will not develop PTSD. But for those that do have it, this disorder is significant. Women are more than twice as likely as men to have PTSD at some point in their lives. And according to the National Center for PTSD, there are a few reasons why women might develop PTSD more than men. Women are more likely, basically, to experience sexual assault. So the statistic is 1 in 3 women will experience a sexual assault or a child sexual abuse in their lifetime. And sexual assault is more likely to cause PTSD than many other events. And women are also more likely to be abused or neglected in childhood and to experience domestic violence. and they may be more likely to blame themselves for the trauma than men because it's sexual assault and the nature of sexual assault and domestic violence that inherently creates this blame because there's a perpetrator victim rather than, I'm not saying that a war veteran wouldn't blame themselves. I'm just saying that the war veteran hasn't been told by a perpetrator it's your fault, like a woman of sexual assault. So I'm not saying that one, and I'm also not saying that one PTSD is worse than the other. I'm just trying to explain why women might blame themselves. And so 30% of Vietnam War veterans may have PTSD, and then the thought is, and the statistic is that 1 in 5 service members who return from Afghanistan and Iraq have symptoms of PTSD or depression. So again, but we're going to get into that. Okay. So why might some people develop PTSD, and why might others not? So the risk factors, like I talked about, violence, were they injured? Was somebody else injured? Seeing other people hurt or killed? Did the person feel horror or helplessness? Do they have social support? And really, people can overcome trauma. It's amazing how resilient humans are. I love it. And they can overcome it with one connection. I've seen people overcome it with the love of a dog, and they were in the mindset of interpreting that love as this person being important. So people are amazingly resilient, and they can overcome this. But the more social support you have, the more people understand the level of trauma and how that could have impacted you, the better that is for your outcome. That lowers your risk. And then also the stress after the event, loss of a loved one, if there's pain or loss of a job or your home. So it's not just the natural disaster. It's that you lost your home and you lost all your photos and you lost where you grew up. It's all that kind of loss that compiles into it. It's not just being injured in war. It's the loss of a leg, and you're not going to walk the same way. So it just compiles, and depending on how much it is and how much stressors that person can endure really will determine their level of risk with developing trauma. And then also a history of mental illness. I mean, if this person is already prone to having depression or they have a hard time coping with everyday stressors, then PTSD might just throw them over. I mean, having a traumatic event might throw them straight into having PTSD symptoms. So another thing is resiliency. So obviously having the good support network, but maybe they don't, but they're really good at seeking it out. Some people draw people to them. They're very appealing, they're very friendly, you just like being around them. Those people tend to be more resilient because they seek out that love and that care. They may not have parents they have a good relationship with, or siblings. You can't pick who you're related to, but you can pick who your friends are. And maybe they have a vast array of very supportive friends. Maybe they chose a great spouse or partner who's very supportive. So that's a resiliency factor. Finding a support group after the event, really that's about being validated. They're validated that it was a trauma. They're validated there's nothing wrong with them and that what they're feeling is normal and that other people, that they're not alone. And then feeling good about their own actions. So if they feel like they fought or that they did what they could or they overcame the perpetrator or they were a hero, then they might have less of these symptoms of PTSD. Having ways to cope. We learn that from a baby. If they had great nurturing parents that taught them how to self-soothe from the beginning and they knew how to take care of themselves, then they might be more resilient to PTSD. And then feeling like they responded effectively. So that's kind of like that hero thing. They felt like they acted and responded effectively, even if it was to sit and freeze where you're at and don't move. And they knew that was the most effective way to respond. That can help them overcome the trauma. And what I do want to say is that there's this phenomenon called traumatic growth. And people, while I would never, and these people will tell you, they'd never wish trauma on somebody, but they're different. They found meaning within themselves. Not, I don't mean like this trauma happened to me for a reason. I don't mean that. I mean that this happened to me and I grew stronger from it. And that can be a very healing and amazing impact, and people have done amazing things coming from trauma. So I do want to say that that's another part of that resiliency. Okay, so these are some myths that we have about PTSD. So a lot of times people think that this condition is exclusive to veterans. That only veterans have PTSD, nobody else does. And on that flip side, we also think that if you're a veteran, you must have PTSD. And so, and this is probably because, especially in the news, you know, in the past year, we've had a lot of news about veterans with PTSD. But this condition is not new, and it's not exclusive to military veterans. Of course, there's certain things that happen when you're in the military that would cause trauma, of course. But that doesn't mean that everybody developed trauma, so we can't assume that. And the other myth is that employees with PTSD are going to have violent outbursts, they're going to hurt everybody, and they're going to disrupt the workplace. So let's stay away from them, they're not safe. So PTSD develops differently in different people. And so just because someone has a diagnosis doesn't mean they're going to cause a threat or be a problem. A lot of people would have PTSD that you may not even realize it. And they're very unlikely to pose a threat. And there's other things that cause, they're correlated to violence, such as alcohol and drug abuse, past criminal history, having witnessed family violence, having high levels of anger or irritability, or someone who is, so it's someone who's desensitized to violence and they have limited self-control. That does not have to be a PTSD person. It's somebody who is comfortable with a certain level of violence. And that is your higher risk of, so that history of family violence is a very high risk. And alcohol and drugs. That doesn't mean that everybody that had a history of family violence is going to go and beat up people, but if they have an inclination towards violence, all these factors play a role more so than PTSD would play a role. And the way I look at it is when you're looking at PTSD, look at it as fear-based. It's not aggression-based. The reactions that somebody has, and they didn't develop PTSD because they were angry or aggressive. They developed it out of being in a very fearful situation. So they're going to respond out of fear. So if you have somebody who's having a violent reaction, are they trying to push people out of the way to run out of the room? Is that what's considered violent? Or are they actively going towards somebody? Are they feeling threatened? You know, that kind of thing. And you may not ever know that somebody has PTSD. And just because they're violent doesn't mean they have it. But, you know, it's usually a fear of being hurt, and they're responding accordingly. And then all employees with PTSD will need extensive and expensive job accommodations. Like I said, you may never even know. And they may have learned how to cope with that, and they may have grown from that. Or they may be seeking treatment, and they may respond, and they just may be withdrawn. You know, that might be what you see. They may be I've seen people with PTSD that are extremely compliant and very withdrawn and rule followers, but they have horrific nightmares, and they have numbing out features, you know, things that you may not even notice in the workplace, and they have difficulty concentrating, but they've worked around it. So let's talk about some facts. So although their injuries may not be visible, people with PTSD may face difficulties with employment. So there could be a problem. So I'm not going to act like there's not ever an impact on their work. Like I said before, these individuals may experience sleep disturbances, anxiety, poor concentration, and among many other symptoms. And all of these have the potential to interfere with everyday activities in and out of the workplace. But keep in mind that not all cases of PTSD are the same, and nor are they all severe. And many people don't even experience any noticeable problems at work. So employment, though, can play a very positive role in the recovery of a person with PTSD. or actually any behavioral health issue. So employment enables many people with physical and emotional disabilities to fully participate in society. And so it provides an income that's a key to that individual and the family's economic well-being and independence. Employment builds skills for future well-being. It provides greater social interaction and connections that can reduce feelings of isolation. It provides a valued social role in our society and helps improve self-esteem that further contributes to life satisfaction. And according to the National Council on Disability, people who regain employment following the onset of a disability report greater life satisfaction and better adjustment than people who are not employed. So for that reason, gainful employment can be one of the most important components in the recovery and rehab of a person experiencing PTSD or recovering from being involved in a traumatic event. So I have some suggestions. These are simple things. And Sherry, feel free to add in or whatever. But this is if you know somebody, they've told you they have PTSD, and I know you guys are going to have another follow-up on reasonable accommodation, so I don't want to really cross over into that, but I do want to say there are some little things that can help. And then, of course, talk with somebody like Sherry in your reasonable accommodations department. So giving them rest breaks, they get overwhelmed. Okay, that's fine. So most of you are somewhat flexible with the time. Giving them, if you need to take a rest, just let me know. You can have a code word. Hey, I need to take a rest. The flexible schedules, that doesn't seem to be a problem in most of DOI when I'm working with supervisors. Doing those more difficult tasks just at the beginning of the day rather than at the end when they're more fatigued and more, and tired. And then sometimes just having, I don't know if you guys know what a white noise machine is. You might see it, it's basically, it's called a white noise machine. You can get it on Amazon. But it just makes a consistent noise, and it just kind of covers up those outside distractions. So this is all something that needs to be cleared up with your employee too. I mean, I wouldn't, please don't just bring all this to the table if they say they have PTSD and you whip out your white noise machine for them to use. We don't want to make any assumptions. But these are just little things that if they say, it's distracting and I hear other people, in the office and I'm having a hard time focusing, then you could say, oh, have you ever considered a white noise machine? Something like that.
Yeah, Heather, this is Sherry, and I would just, I guess reiterate what you just said a couple minutes ago is that certainly we're not going to approach the employee with these suggestions or assume that they have PTSD, but we can certainly discuss with them the performance or conduct problems that they're having, and, if the employee needs some type of an accommodation, that they bring that to our attention. And then we can work with them through the reasonable accommodation process to provide something like a white noise machine or something that may help assist them in doing their job better, more efficiently.
Okay. Perfect. And so here's a couple other things. I'm just going to skim over it because I think you guys are going to talk more about it. But just knowing that if they say they have PTSD, don't be surprised if they have difficulty with concentration and time management. And so there's things that you can do, but go through your reasonable accommodations program in order to meet the needs that they have. So these, just don't be surprised if they have, like I said, they might have issues with memory. So they might need to use little notepads. Of course, lots of us, especially myself, have issues with memory, so notepads might be good for everybody. But these are just very, very, very simple things. Okay, so do's and don'ts. We don't want to assume that somebody with PTSD even needs assistance. So they might say they have PTSD, and they might even tell you they're getting treatment for it. But that doesn't mean that they need assistance at work or that they're having problems. They may have just shared that with you. So we don't want to be hypervigilant and jump to conclusions. It would help to minimize high-pressure situations. If there's some, and again, this goes into reasonable accommodations, but maybe you can lengthen the period of time that they have to do a project or tell them earlier. Treat them as a person, an individual, and ask what they want. And so be tolerant. If they, sometimes, just as a kind of a analogy, when we're here in Atlanta, and you probably heard about our horrific snowstorm of 2 inches. So it was 2 full inches of ice. But it stopped our city, and I know that's quite embarrassing, especially if I'm talking to somebody right now from Colorado or New York or somewhere that it snows quite frequently. So I'm ashamed to say that. Jon Stewart made fun of us on The Daily Show, but that's okay. So anyway, but it was very traumatizing here. And so what people do when they're in that experience is they have to tell their story. And so what we did is we told our story of how long it took us to get home, who walked home, when they got their car, who stayed at whose house because they couldn't get home, what their family did, was their family worried. This is all what we call trauma processing. And so somebody may come to you and they may share part of their experience. It's really important that we don't interrupt. And then I'm going to talk to you about how to, and you can listen to them. And then you say, you can always introduce the idea of EAP. Did you know that we have an EAP and they have counselors that, it sounds like what happened to you was really traumatic. They have counselors that deal specifically with trauma and know about trauma. And I wonder, have you ever thought about using it here? Here's EAP, and give them the information. You don't even have to know that they called, but you've given that offer to them. If somebody is having a crisis, if they're hyperventilating, just be calm and be supportive. And we're going to talk about grounding techniques in a minute. But you don't want to meet them where they're at. So if they're in a crisis, please don't start yelling at them. Always treat them with individual respect, dignity, courtesy. Listen to them. Really, when I say listen, it means that you can reiterate to them that you heard them. It sounds like that was really scary. It sounds like that was really hard for you. They just need to be heard. People repeat, I've found, when they don't feel like they've been heard. So they might repeat the same thing. They don't feel like you got it. So listening to them and just letting them know you hear them. I'm not promoting you having them come to your office weekly like you're their therapist. I'm just saying that if they're going to open up to you, it's okay to listen to them. And then you can say, I'm not an expert in this, and I really feel like I wouldn't even be doing you justice by trying to be an expert in this. Did you know we have EAP? And then you can refer them to that. But at least you heard them. It sounds like it was really hard. And you don't have to go on and on, because I don't want you to enable them either, or they make them feel obligated, like they have to come to your office and tell you everything that happened. We don't want to set up that kind of dynamic, but just being compassionate and then letting them know what their resources are. Or maybe it's not an EAP resource. Maybe it's another resource that you guys have, and that would be something that you could suggest to them. You can offer assistance, but don't be offended if they don't accept it. Sometimes people just want to do it on their own, and that's part of their growth process, and that's okay. And don't be afraid to say, I don't know, or let me check, Don't be afraid to say, I don't really know how to help with that, but I do know somebody who can. And symptoms may go off and on. So I don't want you to think of, so PTSD, these symptoms can flare up, and then they can go away for a while, and then they can flare up. So I don't want you to think that they're faking it or it's not really there. It's just different times and different events that occur in life, daily life, can flare up these symptoms. We don't know if they're triggered. We don't know what they just, maybe they saw something on TV during lunch, or maybe they had to go search something on the internet and they saw a reminder, or maybe they just got a phone call. And so your patience and support will go a long way. And then, of course, consult with ELR, Human Resources, and then call. If you are concerned, you can always call EAP. You have unlimited management consults. I've worked, and you can call back. I've had several supervisors call me. We do a little bit of work about how to strategize, and then they'll call me back, and then we'll strategize a little more. Just depending on, maybe it might just be a simple thing like communication. How should I say something?
So this is Sherry. I just want to reiterate that point too, because I think that's often overlooked by supervisors, that the EAP is a resource for you, as well as a resource for employees. So, you know, if you have those situations, you know, you are able to call and get guidance on maybe how to be dealing with a particular situation.
Okay. So I'm going to skip that one. Okay, so let's go back to, so that's PTSD. Any questions about PTSD specifically? I spent a long time on that. Or if you want to chat. Okay. Any questions? Okay. And you can always call me personally and just say, you know, I don't know if this is PTSD, and I'm not, you know, I won't diagnose over the phone, but I can tell you some common features and then help you work with your HR, ELR to do what's in the best interest of, you know, the workplace and the employee and all that good stuff. So we're going to go back to, let's just take, so chances are you don't know the diagnosis of anybody in your office. You might, but you might not. And so let's just look at what are some signs of some mental health issues in general. So they have a change in normal functioning. And it's got to be a change in normal functioning. We're not talking about their high functioning and they're just really kind of irritated that day. This is affects their functioning. So they have a decrease in productivity, chronic lateness, and that could be anything from drug and alcohol abuse to depression. They can't get out of bed. Taking excessive leave. It's difficult to stay at work. Something's bothering them. Of course, if they look different, they aren't keeping themselves up like they normally do. They're missing deadlines. They're just not real motivated. They used to be that team player. You'd have a team meeting. They always had a suggestion, always involved, always as they say, leaning in. More irritable, not really receptive to feedback, defensive, arguing a lot more. So this could all be distress. It could be mental health issues, but something's going on if they've changed. I mean, you may have somebody that's argued since the day you became their supervisor. You know, that's not necessarily a mental health issue. It could just be a really difficult personality. They have difficulty if you just put a standard, you know, show up on time, only take an hour lunch. I need you to complete this task in a week, which it shouldn't be a problem at their level, completing that task. The workload's not overly high. They're not complaining about workload. So they're just having more difficulty than usual. They're not interacting with others as much. They're maybe describing having more arguments at home. They're not as engaging. They used to go out or eat lunch with people. Now they're not. They used to go out after work with people. Now they're not. Of course, impaired judgment. They're just not making good decisions. They're forgetting what you told them. And they're moody. So these are all things. But again, I want you to notice a change in functioning. You know, again, if they have always taken excessive leave, that may not be a mental health issue. Or they've always been kind of isolated. They're an introvert. That may not be, that's a personality, that they're introverted. That's not that they have a mental health issue. So again, just noticing something different. But you are always welcome to call EAP if you don't know and you notice this change and you're just not quite sure. So I'm not asking you to diagnose them and then call us and say, I've decided that this person has bipolar disorder and I needed you to get them some help for that. You know, that's not what I'm asking. I'm asking that you just notice they have this and you've talked about that symptom and they seem to be doing that. And I just, you know, the productivity is low. So it really comes back to EAP is geared towards when an emotional issue is affecting work productivity. If you've got those two, then EAP is definitely the way to help with that. But you're going to see it more on performance level. So not every manager wants to deal with this or think about it or get involved. So why? One, you may be afraid of jeopardizing their career. You may be afraid of how this is going to impact their future. What if they want, what if they're up for a promotion, but you're noticing that they're not performing the same, they're more irritable, they're showing up late. You know, you think, oh, well, you know, that's what Heather talked about with that depression. And you're afraid if you get them help that they're going to be jeopardizing. But this is actually you noticing. You may be the only one that notices. You may be the only one that realizes anything's going on. And you can recommend to them just to call EAP. And it's confidential. You guys will never know that they called us. We can't tell you. According, you know, HIPAA law dictates that we can't tell unless that person gives us permission. But if they're to the point where they need a supervisory referral, then ignoring it is not going to help that employee get where they want to be anyway. Sometimes we feel like it's a personal issue and that we should just stay out of it. A lot of times you have a personal relationship with the employee and you feel like you're prying or you feel like they're going to hate you for saying this. You might be afraid that they're going to retaliate or file a complaint against you. Maybe you just don't want to be the bad person. You just don't want them to be mad at you because you're, and again, you're thinking, oh my gosh, I'm going to go to Susie and tell her husband just died, and I'm going to go tell her that she's got a problem. You know, I don't want, she's going to hate me. She's going to think, who are you to tell me I have a problem? Not wanting to work through the red tape. Maybe there's a lot of documentation that goes with a referral. Maybe there's a lot that goes in the client's file, or maybe you have to go, oh, I don't want to have to notify this person and this person and that person. I'll just forget about it. And like I said earlier, the fear of response, the employee's response. So what happens when you avoid? Well, what I see the most, so you get all of these impacts, right? And so what I see the most is other employees get really agitated. And what I see is people start to feel like they're walking on eggshells around a certain person, or that certain person's being treated differently. And the truth is, it starts to become enabling. It starts to be like, okay, I know you're having a problem. I don't know what that problem is. Maybe you do. I know that you're having a decrease in work performance, but I'm just going to avoid it. So now that person's allowed to have a decrease in work performance while everybody else is held to a different standard. And then you've got unequal treatments. And really, you're allowing that person to continue in that mental health issue and not ever get any help. And I say allowing, but you're enabling that. And so then people then the workplace morale goes down, there's anger and resentment, and this person who's got this mental health issue that could really benefit from some help just by offering it. And ultimately, you can't force anybody to go into EAP. You can't force anybody to go to a medical doctor. But you can at least offer and you can at least show them how it can help.
Heather,
go ahead. Yes.
Barry. You know, and this is typically where supervisors call employee relations when they start having complaints from other employees about, you know, Susie's not pulling her weight, or she's missing deadlines, so I'm not able to do my part of the project. And it would, I think, be much easier if, you know, you start dealing with the issue when you first start observing some of the signs that Heather just went over, the chronic lateness, the excessive leave, and start setting your expectations in terms of how you're, you know, the conduct and the professionalism that is expected at work, or what the performance standards are that are expected. So you've laid those expectations out to the employee, and you can address them as things come up, and hopefully through that process they will recognize they need to maybe take advantage of the EAP and start getting some help with this, because otherwise you are, as Heather said, enabling or basically condoning the continuation of the poor performance or the poor conduct. So from my perspective, I'd rather get involved earlier than later.
Right.
When you start
and it sets up a dynamic, too, where you've enabled, you know, I say you, a supervisor's enabled the employee for this long. They've gotten away with showing up late. So then what happens during the performance eval, or what happens when they have to be called on it because it's so glaringly obvious? They don't realize that there's a problem. So it's really not fair. It's a complete setup, actually, to tell somebody it's okay what you're doing, and then all of a sudden they get in huge trouble for it. Ultimately, maybe they switch supervisors, maybe whatever, and maybe you're that supervisor that this employee was enabled and now they're under your care and they're acting like you're, you know, the devil because you're calling them out on some behaviors. And it's not fair to the employee because now they're in even deeper distress. And so offering that EAP and noticing, just commenting that you notice it. You know, I just want you to know I've noticed that you've come in late several times. And I've noticed this, and I don't know if there's anything going on with you. It's really none of my business. I respect your privacy. But did you know we have EAP? Offering it that way, just from the get-go. And then if it becomes a problem, then getting ELR involved and saying, but at least you have set up a pattern where you've noticed it and you've given them that honest communication. Because that is the true definition of compassion, is being honest and being respectful. And so, well, that's my definition. I'm not quoting Webster, but, you know, and being that honest, but not enabling and letting them go down this path where they think, well, it's fine. And then they're just going down this path of destruction, essentially. Because what may happen is they may end up getting themselves fired or terminated or dropped down a level or repositioned or whatever, and they haven't had the opportunity to make that change until it's too late. Do you agree, Sherry?
Yes.
Okay. So what I want you, I don't want you to diagnose. I don't want you to be a counselor. That doesn't mean you can't listen, but again, I don't want you to feel like you're in a position of being a counselor. You can always hear them out and then explain to them, you know, out of respect to you, I'm not an expert in mental health. Sounds like you're having a really hard time. Here's EAP, and I can call them and put them on the phone right now, and then I'll walk out. If you want to do that, I think they'd be a great benefit. This is exactly what they're here for. Like we talked about, and I just kind of, I'm sorry.
Oh, I was just gonna insert that, you know, there are sessions that every employee has, up to 6 one-hour sessions with EAP that would not be charged to leave. So, you know, they can take time off to contact EAP and not have to take their annual leave for those first 6 one-hour sessions.
Yes. And also another way that if you just want to confirm that they went, you could just bring back a signed appointment, have them bring back a signed appointment card so you can confirm and approve that leave. And that way you know that they went, but you also can give them that time. Again, I know I harped on it. I kind of got on the soapbox about it, but I apologize. Treat employees equally. You know, if your employees are gossiping about, oh, they're crazy. I mean, he's psychotic, you know, or whatever. Just discourage that. It's not respectful. If somebody has something like they're dealing with something like PTSD and they're just having a hard time coping, it doesn't make it any easier when employees are gossiping. And then that does turn into bullying. And I don't mean like hitting and punching. I mean isolating, not including, thinking that person's weird. Then that's a form of bullying as well.
And I think one of the difficulties that supervisors have in this regard is when, you know, they're not able to share all the information that they might know with the peers of the person. So it can be sensitive, but, you know, you have to maintain confidentiality of the employee if you do know any medical conditions that they might be experiencing. So, you know, it really is a tough conversation when, if an employee approaches you, another employee approaches you about, hey, what's going on with Susie? You know, you have to be sensitive to Susie's confidentiality. You can't really do a lot.
And you can have a conversation with that employee. Let's say employee comes in about Susie. You can ask the employee what they've noticed, you know, and go from what that employee does and then encourage more positive, respectful behaviors, right?
Right.
Okay. So I don't want to say anything that's against your policy. I figured you could do that. But take the employee's lead that's complaining and then just encourage them, well, what do you know? is that something you know? And if it was happening to you, would you want somebody else talking about it? You know, so let's say, you know, you said she's depressed, employee. You said Susie's depressed. So, you know, is that going to help her? Or should, you know, what do you think would be beneficial to help her? You know, that kind of thing, turning it back around. Documentation, document is very important. Again, I'm not trying to, oh, they have a mental health issue, document it and get them in trouble. That's not what I'm saying. But what happens so many times is somebody will call me and there's been this history with this employee and they want them help and they haven't documented anything. There's no documentation, so there's nothing to back them up. And then that just sets the manager up. It looks like it's unfair treatment when there's been years even of noticeable behaviors of decreased productivity, poor work relationships, you know, all that kind of thing. So just document it and justify why there's, you know, this lowered productivity, there's this work performance issue, and you think it warrants EAP because there seems to be some sort of emotional issue going on. And it kind of helps you to make that a clean referral.
And from an HR perspective, I guess if there are, you know, documenting issues is very important, but there may also be follow-on disciplinary action that is required which becomes part of that, the documented history of the individual. You know, you don't have to ignore the bad behaviors. You can still deal with the bad behaviors, and if it warrants some kind of formal counseling or formal disciplinary action, then you know, give me a call and we're going to work through that process.
And just because somebody has a mental health issue doesn't mean that they can't be great performers and function very highly.
Absolutely.
And they need to be treated as such. And they're at that job. They got that job for a reason. They're able to do that job. And sometimes you do have employees. I know you have certain people that you've employed under certain, I guess, acts, for lack of a better term, that have come with diagnoses, and you've made jobs accommodating those diagnoses. And then they'll talk more about job accommodation in the next training. But I want you to be sensitive, be aware of mental health issues, but I don't want you to feel like people with mental health issues can't perform their job. Okay, so let's look at emergencies. So you have an emergency. It's really important during any kind of mental health emergency that you're very calm, and because that will help you make very constructive decisions. You're going to feel rushed, you're going to feel anxious. Take a deep breath and just remain as calm as possible. And your calmness will also help the employee remain calm. So speaking calmly, sorry. I'm going to go into that in a second, sorry. These are types of emergencies. And so they're obviously visibly upset. They're under the influence of a substance. They're threatening suicide, or they're threatening to hurt somebody else. So these are the 4 major emergencies. So there we go. Speaking calmly is very important. If an employee is panicking, your calm manner will reach out to them. There's actually this, I don't know if you have heard about it, but there's mirroring neurons. If somebody smiles at you, your mirroring neurons in your brain are going to naturally provoke you to smile back. Not always, but if they smile at you long enough, it's going to be almost impossible not to smile back. If you're calm, you're projecting that, and they will literally, hopefully, respond to it. Some people, certain disorders don't have mirroring neurons, but it might, you know, it can't hurt. But being that calm, taking deep breaths can help you make a more constructive decision. And then you want to just listen without judgment. Like I said, let them know that you heard them. It's not approving what they're saying. They may be in a full psychosis, and they may be saying all kinds of things that don't make sense, but reflect the feeling. So they're in a psychosis, but they're acting all agitated. You could say, you sound upset, or you seem stressed out. That sounds stressful. So you're not agreeing with what they say. You're just acknowledging how they feel. And that simply can bring somebody down to a calm level because they felt heard. People escalate when they feel like people don't understand or people aren't heard. Sometimes people escalate because they can't hear either. But these are all just different techniques to use. So just remember that these mental health issues are not the fault of the person that has them. When somebody's in crisis, the most respectful thing that you can do is allow them to have their space. If it's possible, to let them have a private privacy, and if it's safe. So safety first. If it's safe, it's usually safe when somebody has an outburst or has some sort of crisis. In retrospect, if they come out of it, they don't want to know that everybody was staring at them the whole time. You know, that's kind of embarrassing. But also, it keeps everybody else, you don't want everybody panicking in the office either. So trying to give them some space. Don't lock yourself in a room with them. Don't have them blocking the door or anything like that. But if it's possible to have them just kind of regroup in another area, then do that. But again, weigh the safety of it. And try to prevent the gossip like we talked about. And you don't have to say why they did it. You can just say, I know all of you saw Susie have that, poor Susie, gosh. I know all of you had Susie have that, saw Susie have that reaction. Let's all treat her with respect and not talk about it and gossip about it and just, you know, do what we can for Susie as supportive coworkers. So again, you're not relaying any information, you're just using what was obvious because everybody saw it. If an employee is emotionally acting out, like I said, it's better to remove them than keep them with other stuff. You might need to figure out how you can best work with them. If it's possible and you have time, you know, they're just kind of agitated, they're acting irritable, and you can remove them and then call EAP and say, you know, I've got this situation. If you have time, I'm not saying in the middle of a full-on crisis, and then see if we can help. I've had people call me, they'll put me on speaker, and they'll say, hey, this is George, I have Joe here in my office. He's having, you know, he's kind of seems a little irritated. He agreed for me to call you. He sounds like he's having a hard time, so I just thought I'd put him on the phone with you. He told everybody outside that he wanted to punch him all in the face. So you're telling me exactly what happened. He's right there. There's no secrets. You put him on the phone with me, take it off speaker, give it to him, leave the office, and I can talk to him.
But I think, Heather, that's if the employee agrees to that.
Yes, they have to agree. Yes.
Yeah, because we don't have any mandatory referral ability, basically. So.
Okay. And yeah, that's definitely if they agree. And that's the most respectful thing, too, because, again, even if you had a mandatory referral, forcing somebody to go see a therapist is not effective. It's only effective when that person's made a choice to make a change. But I can help you guys on, and ladies, on coaching them and teaching and showing them the paths that they're going down and how EAP can help and what the goal is and looking at the overall goal. And I can help with that as far as helping the person see why you're offering, because it is a benefit. It's not a punishment. It's purely, I want to help you, and letting them see that that's where you're coming from. Okay, so sometimes an employee may have an extreme panic response, or they've lost awareness of where they are or who they're with. That's when somebody really has a lot of anxiety, and they look like they're probably feeling scared or out of control. So this is not for someone who may be aware of their surroundings. But so this is someone that's like in an extreme panic attack. So what you want to do is speak very slowly and calmly and have them breathe deeply. So again, I'm not trying to teach you to be a therapist, but I'm just trying to give you a technique to use in that moment. So if they're panicking, remind them of where they are and have them talk to you about what they see in that room. So if you're able to get them in a room where it's safe and you feel safe being in that room, they're not making threats to you, they're not making threats to other people. I mean that they're just having a panic attack. They're just kind of lost awareness of where they are. So you say, okay, look at the floor, count the little, if they have shoes with eye holes in them, or count the tiles on the ceiling. Generally changing positions is very grounded, so if they're panicking and they're standing, have them sit down. That movement gets them grounded. And tell them, remember, you're here in this office, we're in the conference room. Do you see the chair? How many chairs do you see? You know, something like that. And it sounds really elementary, like juvenile, but it really will ground them. You're reminding them of where they are, and you're very calm and you're very comforting and just getting them back to the present reality. Okay. All right. So employees under the influence. Know your policies and procedures. So Sherry is a great resource for this. Determine if they need medical assistance. And again, I'm not asking you to be a doctor, but if they're, you know, collapsed on the floor, obviously call 911. You know, and I'm, you know, Sherry, you might want to intervene in this one. If it's not a medical emergency and they're intoxicated, I've had people transport them home. Is that within your policies?
Yeah, I mean, I think we need to find, obviously we're not going to allow them or shouldn't allow them to drive themselves. We, I think for the most part, probably have an emergency contact that we could call if it comes down to you or a coworker taking him home, if that's, you know, the last available option, then I think certainly that's okay. But, you know, we don't want to allow them to drive. If they just need to sit someplace and, you know, sober up a little bit, you know, you can put them in if you have a private room that you can put them into. If they refuse, I've had supervisors, you know, say, well, if you leave here and you drive, I'm calling, you know, and reporting, you know, that you're driving on the road. Because I've had, you know, employees who have refused to ride home. So, you know, certainly that's an option, too, if you can't get them to reason and allow someone else to take them home.
And then be aware of if they can perform their job duties. I mean, obviously, if they're blatantly intoxicated, but if you have a concern about them and their job is to drive at the job, or they operate heavy machinery, or they're in a safety sensitive position, you know, follow your policies and procedures, but be aware of what their job actually is if you're concerned about them being under the influence, even if it's engaging with public, or, you know, you just feel like they're impaired to. I'm not saying, you know, let them work if they're a little drunk. That's not what I'm saying, but I'm just saying, you know, if you have some concerns, be aware of how that's going to play in the job as well. And document everything specific and objectively. So what do they look like? How are their pupils? What is their appearance? Do they have an odor? What's the volume of their voice?
Yeah, like what you talked about earlier, you want to be very factual in what you observe, that, you know, that they were slurring their speech, that they were staggering down the hallway, that they had an odor of alcohol, their eyes were bloodshot, you know, all the typical signs that we all have seen, I'm sure, at one point in our lives or another. And then I would, you know, again, have a second opinion or a second observation by a manager. We don't want to involve a coworker in making those observations. And document those.
And then, okay, so perfect. Now, if they threaten suicide, if you were on my call this morning, it's going to be a little bit of a repeat, but take all statements seriously. I don't care if they said it every day for the past year. We take it seriously because, again, even if they said it and they're not serious about it, it causes distress amongst their fellow employees, and also there needs to be a boundary. They need to know at minimum that you can't say that kind of thing at work. Now, I'm saying that at a minimum. Obviously, their safety and well-being is number one, but if it's that person that keeps saying it, there needs to be a boundary set there, and that they need to know that when you say something like that, I'm going to take it seriously and I'm going to respond accordingly. So then you listen, what's going on? What does that mean when you say the end is near? And then notice if the statements are direct or passive. I'm going to kill myself, or I wish I was dead. A lot of people say, I wish I was dead. They don't necessarily have a plan or intention of hurting themselves, but ask, do you have a plan? What's stopping you? And do you have a means? How would you do that? So I don't want you, again, I don't want you to go into being a therapist, but we need to get a little bit of specifics, because we need to know what we're dealing with, you know, because if they say, I wish I was dead, and you just let it go, well, what if you said, well, do you have a plan? Well, yeah, I'm going to run into a tree when I'm going to drive home right now and run into a tree. Well, that's an imminently higher risk than just saying, I wish I was dead, and you thinking they're just having a bad day. So that's why it's important to kind of, I don't want you to get too deep into it, but it's okay to ask very specific questions to clarify what they meant. Of course, if you have time and they're in your office, call EAP. That would be my first bet. Call us anytime you're concerned about anybody that's made a suicidal statement. If it's imminent and you feel like they can't be alone because they just told you they had a plan and a way to do it, then usually we have their emergency contact, transport them to the ER, but they need to be at the ER. Worst case scenario, you might have to call 911. And this is when you don't have time to call EAP. They're planning this, they're on their way, they're trying to leave you right now. You know, you have this discussion, I need to keep you safe. They don't want to talk to EAP, whatever. Then the most conservative way would be to get your, 911 to get them to the ER or get their emergency contact to get them to the ER. You just have to weigh what would be the most productive. You don't want to call 911 if they're willing to have their emergency contact taken, And I'm going to say trust your instincts. I know that's a wonky, wobbly statement, but if you in your gut feel like something's really bad wrong and you couldn't sleep that night knowing something happened, then I want you to trust your gut, and we need to do something to help keep that person safe. And like I said, please always call EAP and consult with us. We're all trained in crisis management. We're all trained in crisis intervention. We all know how to do a suicide assessment and evaluate for risk. And we will help facilitate getting them where they need to go. But if for some reason there's just not enough time, sometimes you just have to do what you have to do, and that might mean, to the extreme worst case scenario, calling the police. But please follow whatever policies and procedures, and please don't get in the way if they say, I have this gun right here, I'm going to, not right here, but like in my car, I'm going to do this. Please don't get in the way of trying to get in a battle over a weapon or anything like that. Keep yourself safe, too. You're just as important. Okay, so if an employee is threatening violence against others, again, take all threats to harm very seriously. This can be very stressful, and so take it seriously. And know your policies regarding violence in the workplace in advance. So if you don't know them, look them up or talk to Sherry and figure out what they are exactly. I think you guys all know them, though. And also understand it's important to keep yourself safe as well as being aware of the safety of your employees. If someone's threatening, some helpful tips are to stay close to the door. Don't be in a position where that employee is blocking you from an exit or other employees from the exit. If you can get the threatening employee out of the main area and away from the other employees, that would be helpful. Don't put yourself in danger by blocking in the threatening employee, okay? And I believe you guys all have some security type people around, correct? Does everybody, a lot of offices or a lot of areas have? Okay, all right. So if you feel like I'm sorry, go ahead.
I said some is local law enforcement, some would be federal protective services, depending on location.
Okay, all right. If you feel like the employee is at immediate risk to others, it's important to contact 911 as needed, like you said. And keep in mind that they might need some stabilization, and 911 will be able to determine if they need to go to the hospital or they need to go face charges or whatever. But sometimes it's an unstable hospitalization type thing going on. And please notify the police if you know of any weapons that are involved, and don't get in the way of trying to remove any weapons. Risk for homicidal intentions and violence to others is higher if the person makes a blatant statement, like, I'm going to shoot so-and-so in the head tonight, rather than if they say, ugh, I can't stand them, I wish they'd just drop off the planet. The risk also increases if a person has access to a weapon and a specific victim. Another factor is to consider work history. Has this person been transferred to job sites multiple times, and why? And do they have a history of threats of violence? And knowing that will help you also kind of look at the risk involved. But again, trust your gut. If you don't feel safe, do what you need to do to stay safe. Okay. So again, I know I've talked about it numerous times. But EAP can offer advice, assistance on how to document observations, how to engage the employee, how to have this interview with the employee, and how to refer the employee if it's appropriate. And again, you have unlimited consults. And so here's our number. If you're on the phone and not on the call on the webinar, it's 800-869-0276. And then you can also get services at eapconsultants.com, Interior EAP. And then the last page, which you guys will all get on the handouts, I'm sure Lori will have them emailed to you or have them where you can access them. There's a list of resources and websites you can go to.
Hi, this is Lori. They're on the portal in the admin training area. We can go over that in a minute.
Okay. So are there any questions?
So this is Ed Keeble. I'm going to start by making a couple of comments, and I have one question. So my first comment is I want to thank you very much for this training. You've provided a lot of information that should help all of us be better supervisors. The second thing I want to say is to my colleagues on the phone that I want to be really clear that the work we do is really important, but for those of us who are supervisors, there's nothing more important than how we manage our people. So I want everybody to really reflect on the information that Heather and Sherry both shared with us today. And so my question is, you talked a little bit about how we can contact you and a little bit about what you can do for us as managers. My sense is that Sherry is right, that most supervisors here on the line have probably always thought about EAP as a resource for employees, not for managers and supervisors. So I'd like to, with all of the really good information you provided, the one thing that I want people to take away from this is that you are a resource for managers. And so maybe it would help a little bit if you could explain the skill set of the EAP staff and the mechanics of how we reach out. I appreciate you gave us your contact information, but what happens when a manager reaches out to EAP? We call the number. What's going to happen when we call that number? And maybe if you could give one sanitized example of how you've helped a manager work through one of these mental health issues.
One way is sometimes a manager calls me to make a referral, but they don't know how to make a referral. They can tell there's something obviously bothering or distressing to the employee, possibly a mental health issue. They don't know what it is, and they'd like for this person to get some help, but they have not the first way or idea of how to refer them. So what we do is we discuss the specific situation and taking into account. So when you call in, we have an intake staff, and then we have a group of EAP specialists. And all of us have clinical experience, as we're all therapists or counselors or clinicians, whatever. And everybody that answers the phone is a counselor. But the EAP specialists are a little more, we do management consults every day. We're a little more, I don't want to say skilled. We have a very honed skill set, let me put it that way. And so you would talk to an EAP specialist. And so, like I said, I have a manager who calls. I'm an EAP specialist. So they call in. They want to know, how do I even approach this employee? So we take all the factors into account. What is their rapport like? What is this employee displaying? What is their motivation? And we talk about all these different features of what would appeal to the employee as far as getting help. What's in it for the employee? Why would they want to go to EAP? And so we explore that, and then we have a way, and I coach them very specifically on how to talk to that employee in a way that the employee may be the most responsive and understand that the intention, because we have intentions, but sometimes our packaging is really bad. And it gets lost, and all the employees hear our words. They don't know our intentions. But if we express them in the right way, then they'll understand where we're coming from, and then they'll be more receptive to getting that help. It also warrants whether there's going to be some sort of feedback. A lot of times with drug and alcohol abuse, because all of us know how the treatment process goes with drug and alcohol abuse, or addictions, and so we might have a different response and what kind of feedback you're going to want back because of this, the nature of this. So other times I haven't made a referral. I haven't said send the person to EAP. I've said, you know, it was simply I have this person who's told me they have PTSD, and here's the, you know, and I take the time. I'm not going to just put you on the phone and in 5 minutes try to figure out what's going on and then rush you off. We're going to take time. We're going to chat about it. And then I just need to know how to communicate clearer. They're not being, you know, I'm saying this and there's not a receptive response to this. Or when we had the performance evaluation, they didn't really like the way, da-da-da. And maybe it was a really poor presentation. Maybe it wasn't. Maybe there's something else going on with them. So again, it's maybe how to just communicate differently. Maybe the person doesn't really warrant that referral. But, I mean, you can always offer it. But I can at least help and assist in that way. Maybe you have someone who came with you with a diagnosis, they're already getting treatment, but you just don't understand what that means. They came to me, they're getting reasonable accommodations for PTSD, and this is what they're getting. Can you tell me why? Why do they need notepads? Why do they need a white noise machine? And I can help explain that. So does that that's kind of the overview of what we can do, but it's really specific. I mean, every management consult is very, very specific. And it also depends on the manager and the dynamic in the office. But does that answer basically what you were looking for?
Yeah, yes, thank you. It's very helpful.
Heather, this is Lori. Is EAP a 24/7 company?
Yes, we're 24/7, 365 days a week.
Thank you.
You know, this is Courtney, and I just want to reiterate what Ed was asking about, saying about managers using EAP, because I found it very helpful in dealing with stress in the last 6 months to use their resources.
Good. And, you know, when you're dealing with so many employees, and one employee with a mental health issue can take a lot of your time, and you may not have that kind of time. And I get that a lot, of you're spending a lot of time on one person when you've got million-dollar projects you're working on or whatever. So just remember, EAP has counselors. These counselors are on your insurance panels. But just take into account the stress that you feel. You might need to get your own individual counseling just for that coaching, just for that coping with that stressful situation. If you have an employee that comes to you and says they're suicidal, that is very stressful. Take care of yourself. You don't have to be in lifelong therapy. You don't even have to talk about, you don't have to go all the way back to your childhood. Everybody thinks when you go to therapy, you have to talk about your childhood. You don't have to go back. You can just talk about that current situation and how to deal with it. It doesn't mean that you're weak, but you're also taking care of yourself so that you can cope and it doesn't keep you up at night. If you're staying up at night and you can't sleep and you're worried about your employees, then call EAP and get your own counseling, completely confidential. And so that kind of reminds me too, the people that are covered are temporary, full-time, part-time, seasonal students, employees, and also they're your partners, your spouses, and your children who live in the home up to age 21, and then your children who are full-time students up to the age of 26. If your child is 18 or older, they need to call us because they're legally an adult and they have to get authorization for their own sessions. And you get up to 6 sessions. Any other questions?
All right, well, thank you very much, Heather. It sounds like we're all questioned out. Appreciate your time and energy. It's terrific training.
Heather, thank you so much. I'm sure that we'll be in touch.
Okay, thank you.
Thank you.
Thanks, Heather.
Thank you.
Bye, Sherry. Thank you.